So this is the hot topic of today, is liver transplant in the COVID era. Uh, yeah. So this is the outline first, very briefly about the virus, then how to manage previously transplanted patients, especially their immunosuppression. Second is how to perform transplants during this time. So about the virus, we know most of this. So incubation period is about 5 days. Most patients present to the hospital at about 7 days from the onset of symptoms. Highly transmissible, highly contagious, most commonly asymptomatic. The biggest problem, most common problem for symptomatic patients is pneumonia. While mild pneumonia is, recovers on its own in about 10 days time, but severe is where we face trouble. High risk population is well known to most of us now. Elderly, diabetics, like comorbidities such as diabetes, hypertension, heart disease, pulmonary disease and such. There is some evidence in literature of liver injury also being seen in severe COVID, especially as part of the multi-system involvement. What we have also come to realize is the infection is not avoidable. All we can do is restrict its spread and postpone the peak. The pandemic, we realize, may take a few years to die down, not months, which we thought initially, until a vaccine becomes available or good antivirals are available or herd immunity may develop, which is actually happening in some parts of the world. And there is a recent report that in Mumbai, there are about 60% people in a certain area which have become immune. So with the experience, what we have learned is that for asymptomatic or mild patients, home or institutional quarantine works well. And for severe symptoms, hospital and ICU are required. And although there are no medicines that have been proven to help, but close monitoring and whatever we have available is what we do. How do we manage previously transplanted patients? So this is the series, all the publications which are single case reports from all over the world, different parts, mostly from US and from Italy. These are the places from which maximum amount of publications have happened. And just a glance at it, it's quite similar to what a COVID patient, non-transplant COVID patient is. Not a very high mortality, only one patient, one mortality in this series, not series, like a series of publications. There is, symptoms are characteristic, the same fever, hypoxia, cough, so everything is similar. Now, what we notice is that there is a significant amount of patients who will demonstrate liver injury, and not all of these patients will have rejection. So a lot of patients will have liver injury, but they will, on biopsy, will not be found to have rejection. So about half of them will have rejection, which can be triggered by a viral infection anyway. But some of them will have a liver injury, which is not rejection, which is as seen on biopsy. What people have done is either they have stopped immunosuppression or withdrawn MMF only, or withdrawn tacrolimus also. So basically at this point, when all this was happening, this is all publications from the last 2 months, nobody really knew what should be done. So everybody was doing the most logical thing. Now these case reports also show that there are some perioperative infections which have also done well, although they did get pneumonia. But there are two cases I would like to highlight. One is this fourth publication by Lagana, which is a pediatric transplant, where the donor was found to be positive, and the donor recovered. The patient never got the infection. And the last case report, which is by Hong, this is again a living donor transplant, where the donor was found to be positive after the transplant. And this case, I'm going to discuss it in a little more detail. So the patient, the donor did not have symptoms initially. Once the donor developed symptoms, they sent the test, but then the test report came back after 2 days, when it was already post donation. So on day 1 of the donation, the report came back positive. So they did give lopinavir and ritonavir to the donor, but for the patient, this UD is undetected. So for the patient, they tested multiple times and the patient never came back positive. Although they did give antivirals, which we know don't work, and the hydroxychloroquine, that again we know doesn't work. So this was an interesting case. What they concluded, there are a couple of things, and this was an ABO incompatible transplant. So the patient had already received rituximab and plasmapheresis before this, so they could not really change anything at that point. So what they in the literature review of this paper, there are a few interesting things that they have said. One is that the virus doesn't have very significant presence in blood or plasma, and they have checked this on the histopath of the liver also. So only about 15% of people who will develop COVID infection will have viremia. The others, the disease is very restricted to the lungs. So they have, in their discussion, and they have quoted another paper here where they've said that non-lung organs actually could be donated and could be used for transplantation. A controversial point, but this is one of the interesting things from this paper. One of the cases from Delhi, where a patient who was quite sick, apparently the child was quite sick, and underwent a transplant after the donor was positive, and then 3 weeks later, after the donor became negative, they went ahead and did the transplant. The standard recommendation may be a little higher, but this was also successful, uneventful, absolutely. Now, this is unfortunately, the literature of case series is so sketchy because some of these case series are just few sentences in another article. So anyway, so this is a series of 3 kids who had COVID positivity from Italy. Out of about many transplants, they did state the number. And this is the first one, D Antigua. But the second one is from 640 transplants. They found that about 1.25%, that is 8 patients were positive, most commonly males, and about 3 months to 4 months after transplant. 75% of them were on CNI and MMF, standard immunosuppression. 50% of them have had comorbidities. The symptoms are quite similar to our routine COVID patients, but there were no mortalities, so all of them recovered. Now, this is an interesting another paper. This is where this is also from Italy. What they noticed was that patients who were long-term after liver transplant, more than 10 years, and also had much lesser immunosuppression, did much worse than compared to patients who were short-term after liver transplant. Within 2 years. So they divided all the transplant patients less than 2 years, 2 to 10 years, and more than 10 years. And this was their finding. With that, they concluded that patients who have a higher immunosuppression, which is full immunosuppression, that is about 10% in the long-term patients and 70% in the short-term patients, they tended to do better because their hypothesis was that they were able to avoid the cytokine storm. Having said that, these groups are also quite different because the long-term patients also have more comorbidities, and therefore it may not be a very accurate conclusion from this, because all 3 mortalities were in the long-term patients and none of the mortalities were in the short-term patients. Having said that, because the comorbidities are higher in the long-term patients, we don't know whether this conclusion is going to be valid. So we looked at some more papers. So this is the series from New York. 38 patients had infection out of all the transplants that had happened in that before that, like in the past. So these are patients who have previous transplant who have come in with a COVID infection. Out of this, only 21% of these patients had transplant within the last 1 year. We are not talking about mortality, only incidence of COVID. So the incidence of COVID doesn't depend on really whether you are early or late after transplant. The interesting finding here is that there is 42% patients also had GI symptoms, which is quite out of proportion to, and 57% had AKI, which is quite out of proportion to what you see in COVID patients, non-transplant COVID patient, like a standard COVID patient. So this was a little intriguing. So of course, we looked at some more papers, but in most of their papers, patients, they reduced immunosuppression and had some rejections, which were easily reversed. 7 of these patients, they lost 7 patients, which is about 18% mortality, which is again a little higher compared to a standard COVID patient. Now, this is a survey paper from 57 patients across 19 centers, European centers, 70% male again, so very similar to the New York paper. 6 years after transplant was the standard median 6 years after transplant. 55% of their patients had comorbidities. So except for the duration after transplant, the rest of it is similar. Here again, the percentage of patients who have GI symptoms is 33%, quite higher compared to standard non-transplant COVID patient. They found lymphopenia was a poor outcome variable, and patients with cancer, HCC or PTLD, which was in 5 out of the 7 mortalities they had, was higher. Now this probably is again, I would take this with a pinch of salt, because these are all 6 years out patients. And while PTLD, I would agree that they are at higher risk, but HCC 6 years after transplant, not really able to understand well. So they didn't make very significant changes to immunosuppression. Their case fatality rate was 12%. Now, 2 more papers I'll discuss quickly. So this is another series by Webb, a very short paper. This is all across the world. So centers from all across the world, 39 patients reported COVID. They had about 23% mortality. They did not find any difference in age, obesity, other comorbidities, time for transplant between patients who had mortality and the others. And the immunosuppression was also similar. Another database from Europe, from ELTR registry, 103 patients with COVID after liver transplant, 74% male. Again, diarrhea is about 24%. Rest of the symptoms are similar, but diarrhea is 24%, little higher. Case fatality rate is about 16%. So we are coming to a general idea that the case fatality in COVID in liver transplant probably around 15%. Diarrhea may be a little higher than standard COVID patients. Duration may be important in knowing whether in severity or mortality, but we don't know that for sure. Now this is an interesting paper. So this is 272 cases from 88 centers. This included 57 patients who were candidates and 272 patients who were post-liver transplant. So the blue is the candidates, red is your post-transplant, green is the candidates, red is the liver transplant patients, and blue is general population. So they also reviewed the differences in the policies. So just to get that out of the way, only 86% test the donor before accepting them for transplant, 14% don't. Only 69% people mandatory recipient testing, and others do it selectively. So if there is a person who does not have symptoms and has low epidemiological risk, they would not test the donor or the recipient in a lot of European centers. Not a lot, but some European centers. Now, here is an interesting thing. So the candidates have much more incidence compared to recipients or general population in all countries. So this is 1% for the candidates compared to about 0.3% for the general population or recipients. So their conclusion was that the chances of acquiring COVID was much higher in a chronic liver disease patient on the waiting list compared to a post-transplant patient, and even the mortality was higher amongst candidates compared to post-transplant patients, which is about 15%, like we discussed, and for candidates it was about 18%. They found that recipients were more often symptomatic, they more often required ICU, and had higher mortality compared to general population. Now this is an interesting paper, very recent, where they analyzed 111 patients from Spain, again COVID and liver transplant. So the incidence was higher compared to general population, about twice. The mortality was higher compared to standard. Mortality was not higher compared to standard population. So their standardized mortality ratio was 95.5. So just about the same as a standard population. But when they looked at the patients who were on mycophenolate, they had a relative risk of about 3.94. So almost 4 times higher risk of getting a severe COVID infection. Now, if you split it by presence or absence of mycophenolate or dose, a dose of more than 1,000 made much more difference compared to having or not having a mycophenolate. So this was interesting. So even if we're giving mycophenolate, it should be at a low dose, is what they concluded in this paper. Post-transplant care, we know this, it's generally no different from a standard person in the general population. You wear mask, social distance, hand wash, isolate, whatever. And if you take all these precautions, even if everybody around you has COVID, there should be very minimum chances of you acquiring them. And as we discussed, these are the standard COVID protocol management protocols followed in most hospitals. Although we know that a lot of the controversial data exists about each of these, and if we have to state it in short, I would say that most of them don't really have enough proof that they work. Now, some of the things that we've realized with this is that liver injury is pretty common. So different papers state that it is between 14 to 53%, and it may correlate with the disease severity of the COVID. Diarrhea is one of the common presentations. As far as immunosuppression is concerned, there are some papers that say that higher viral load may be one of the manifestations, or even prolonged shedding or prolonged transmission because of COVID, because of immunosuppression. But it may protect against the cytokine storm. Most people say that you should reduce MMF, and especially if the white count is or platelet count is low, or there's diarrhea, which is also common with COVID. If you're going to reduce the TAC, the main reason to do that is if you're suspecting or encountering secondary bacterial or fungal infection. As far as steroids is concerned, because it is one of the drugs indicated for COVID also, most people recommend that you give steroids, at least stress dose steroids. And people who have developed ground glass opacities or pneumonia, you could consider stopping mTOR inhibitors because they can also cause interstitial pneumonia. So, and the controversy about whether patients get more severe infection longer after transplant is, in my opinion, still unanswered. The other thing that we have to worry about is drug-to-drug interactions. So all the arrows that are pointing up show that they increase the levels of each other, and all the arrows that are horizontal show that they don't increase each other levels, and the downward. So the red boxes are where you have to be careful and try to avoid giving those two drugs. If you're giving the yellow boxes, then please check levels of your immunosuppressive drug often. And the green boxes are where you try to give it at a lower dose. Performing liver transplants in the COVID era. So it is primarily going to be governed by the rules that are existing in each country and each society. Most countries have given out guidelines for this, because it's very difficult to get evidence which is reliable with such a short period of time. And we have to also recognize that in different parts of the country and different parts of the world, the resource constraints, especially for ICU beds, ventilators, PPE kits, critical medicines, and blood products, could be very different. So one guideline or one way to manage this situation cannot be applied to all others. Especially because this is a long surgery, the risk to healthcare workers is also higher, and there is also risk to the patients and other patients and their family members. So in addition to the standard risk of liver disease and liver failure and the risk of transplant, and we also have to now factor in the risk of acquiring COVID and the risk of the standard risk. Now this is a paper which was written by Srinivas Reddy, where 6 centers from all across the world participated, 2 from India, 2 from UK, 2 from the US, basically to show that the COVID did make a huge impact on the amount of transplants we were doing. And in India, in both centers, it was the reduction in the transplants was more than 90%. In the UK, the transplants reduced by about 80%. In the US, it reduced by about 60 to 80%. Now, this also showed to us that the reduction in the liver transplant activity was quite disproportionate to the number of cases, because when this survey was done, at that time, the number of cases in the US was hardly anything. And therefore, at that time, the reduction was much lesser. But then subsequently, and at that time, even in India, the number of cases were very little. But the reduction of cases of transplants in India was much more than elsewhere in the world. This is the time when UK was at its peak. UK was the epicenter of COVID when this was data was collected. And this similar findings have been reported by others also. So people who have done transplants during COVID, they have not really faced much of a problem. But in this study, where they've said that their volume reduced by about 50%, they just lost one patient who was also a concomitant HIV positive patient. Now, that's why we have guidelines, and every country in the world, including ours, have guidelines. This is a nice paper where they have summarized all the guidelines from all over the world, and they've divided the guidelines into 4. immunosuppressed transplant patient, so somebody who has been transplanted in the past, and which countries support these recommendations. For example, whether they should postpone the visits, whether they should be provided with the immunosuppressive medicines and stuff like that. And then the second is general management of transplant program. I'll be happy to share this paper if you would like. And then donor, how to manage the donor, whether to test the donor, whether to accept a organ from a donor who is COVID positive, and then the recipient. So this was the most interesting read, and they've given a score for every society that supports that particular recommendation, a positive score; for a society that opposes a particular recommendation, a negative score. And then they've sort of tried to get a consensus based on the guidelines all over the world. One of the interesting algorithms in one of these guideline papers was this one, and this actually is quite good. So basically, first check your recipient on phone. If there are symptoms or epidemiological risk, then get a PCR done, proceed with transplant. If they are obviously epidemiologically positive, don't bother testing, give it to the next patient. As far as the donor is concerned, if they already have a PCR test and it is positive, of course, they can't donate for 28 days. If it's negative, then you could go ahead with the transplant. If the patient donor has epidemiological or clinical risk, then they are divided into high risk, intermediate, and low risk. And depending on availability of test, then you decide whether or not to accept this. So this is a very logical and good algorithm to follow. Something similar is being followed in ZTCC Mumbai, and I'll come to that very shortly. So what they've said is you should have a phased approach to liver transplant. So depending on the pandemic phase in your city or your country, you decide how much of reduction you want. And depending on the percentage of reduction of activity you want, you decide or prioritize patients whose risk of acquiring COVID during that time and of the team taking the risk is justifiable. And depending on that, you choose a certain type of patients alone. So this is again a very good way to look at the whole thing. NOTO, the National Organ Transplant Organization, and LTSI have also given the guidelines. I'm sure all of us will be familiar with this. So they have acknowledged that transplant is risky during this time because of the risk of acquiring a nosocomial infection, and it should be done at dedicated centers. If there is a positive case in the hospital, you should select the transplant team member selectively. Transplant centers should send advisory to their patient, maintain a database of patients who have positivity, assess local epidemiologically, and make a decision accordingly. And they should establish a COVID-free transplant pathway, which most people are doing. They said that we should do epidemiological screening. If positive, then do a PCR. Patients may not manifest symptoms, which is also something that we see. Use Arogya Setu app. Symptomatic patients should be treated either at home or hospital, depending on their severity. Immunosuppression management is on the discretion of the transplant team. Recipient's family members should follow transplant government advisory for travel. They've also said that acute liver failure patients go ahead with transplant. For ACLF or HCC patients, the center should use the discretion. Non-elective transplant, non-urgent transplant should be postponed for 2 weeks, but this was in April, first week of April. So we've already crossed that. And they've given certain guidelines for both cadaver as well as living donor transplants. This is the interesting table from the NOTO guidelines, where they've said that in future, when the antibody test becomes available, then this is what we should do. And now that the antibody test is available, this is a good protocol to follow. So if the IgG is positive, then you should be able to go ahead with transplant. And if PCR is positive, of course, then defer it. And they've also put a checklist for exactly the same thing that we've discussed. So these are the two checklists. So you can just tick yes or no and sort of make a decision whether you're allowed to do the transplant or not. In ZTCC Mumbai, what we have also done is some more additions to this. And we have said that in super urgent cases like these, like acute liver failure, PNF, HAT, Budd-Chiari, Wilson's disease and all, we should go ahead. In urgent cases, which is defined as estimated 6-month mortality more than 60%, more than 50%, which is again defined by ACLF, hyponatremia, which is unrelenting, HRS, refractory ascites, grade 3, 4, HE, MELD more than 25, CTP more than 12, HCC within UCSF, hepatoblastoma. These should be prioritized after the ALFs. And then there are elective patients who will be in a position to wait for a few months before they need it. Recipients should be available locally, even if they are from out of state. And again, this is similar to our DOTO guidelines, but COVID-free pathway compliance undertaking by the hospital that we are complying to all these, consent, healthcare worker screening, clinical screening, and if positive, then they don't participate in transplants for 2 weeks. For deceased donor, a negative PCR and CT test is mandatory in Mumbai. And for this is how it is in the ZTCC and DHS Mumbai protocol, where there is epidemiological screening A, clinical screening B, imaging C, and PCR D. If all four are negative, it's a low risk donor, you can go ahead with transplant. If epidemiological or clinical are positive, but C or D, imaging as well as PCR is negative, then it's an intermediate risk donor, but you can go ahead. If it's C or D are positive, then it's a high risk donor, then you can't go ahead. This is our experience of all 4 global hospitals, which Dr. Dharmesh was also part of. So 31 living donor transplant, the liver transplants we've done over this period since COVID. Most patients were sick, so high MELD scores, high MELD patients. All donors have recovered well. Sepsis related to mortality in 2 patients out of 31 and non-COVID related mortalities. They had standard ICU and hospital stay. Really, the experience was no different from when we used to do transplant for non-COVID patients. So in summary, all these guidelines have been framed and issued generally in April, and few societies have actually revised their guidelines. In June and now in August, we have very different scenarios. So there is need to revise most of these guidelines. If no COVID in a liver transplant patient, there is absolutely no need to change immunosuppression. But if it is there, MMF may be reduced to reduce the risk of severe infection. Immunosuppression withdrawal is not advisable because it may also be harmful. For transplants to be done, a plan based on the phase of COVID pandemic locally should be made. The incidence is higher in liver transplant patients. They are more often symptomatic, more often require ICU, may have higher mortality compared to general population, but it is certainly less than patients who are on the waiting list. So that has to be balanced. Consider the risk of liver disease and COVID, because unfortunately the high risk patients for COVID and the patients who are a typical standard liver transplant patient are exactly the same. About 70% of patients who undergo liver transplant are male. Most of them are now around 50 to 60. A lot of them are obese. So the high risk patients for COVID are exactly the patient, a standard liver transplant recipient of our times. So therefore, it will be very tough to avoid having a high risk patient who are not undergo transplant in this era. So we should though try to reduce the pre and post operative stay and try to avoid using extended criteria grafts so that their recovery is faster and they don't remain stuck in the hospital for a long time. Thank you very much.